The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to this webinar. My name is Sarah Townsend and today we're doing part one of the qualification called Understanding the Needs of Individuals with Profound and Multiple Learning Disabilities. You should have already received a webinar and watched it to show you that explained how to complete the paperwork and how the qualification works. So we're going to go straight into the learning outcomes or assessment criteria as it says on these slides. Today we're covering AC 1.1, 2.1 and 2.2. So let's get started. We're looking at AC 1.1 and AC 2.2, partly because they link so closely together. So we're going to cover them together in one element, and then we're going to go on to look at the healthcare needs. So firstly, if you're doing it at level 2, you're describing, and at level 3, you're explaining. We're explaining the complexities of PMLD. So if you're going to explain them, I want you to give me examples. I want you to include references as well at level 3. So first of all, I'd like you to go to the presentation that you've been sent and find this hyperlink and click on it and watch the YouTube clip that is there. It's about 10 minutes long and it's all about what PMLD means and the type of activities and services someone might access. I want you to think while you are watching this about the terminology used, also about how you might describe an individual with PMLD to someone who knows nothing about this area of work. So I'm going to give you time now to stop the webinar and click on the link and then come back to me. So I'll stop speaking and I'll see you in a minute. Hi, welcome back. I hope you found that clip interesting. So when we're writing up AC 1.1, we're thinking around a working definition. So we're not saying that there is a set clinical diagnosis for the term PMLD. It's more of a working definition. There are more characteristics linked together, and that's what makes it so complex and diverse. So I hope you had time to think about how you might describe someone with PMLD. So we're going to look at some of those definitions now, and hopefully some of the things that you've thought about or written down will come up. So if we look at the acronym PMLD, this is used for profound multiple learning disabilities. So by profound, we mean extreme. So the disabilities that someone have are going to have a serious impact on their life. It's going to mean that they need support in everything they do. Multiple will obviously mean many, so they're likely to have a sensory impairment, which might be a visual impairment and or a hearing impairment. They may have sensory processing disorder. They may have a physical disability, maybe autism. They could have complex health needs. They could have behaviours that challenge. They will have communication difficulties. So often we'll use non-verbal forms of communication. And then they're going to have a learning disability. And that is going to be a severe learning disability. So it will hinder them from learning basic skills. It will mean that they will need support in understanding and interpreting the world around them. So let's look at some other people's definitions. So these are people that maybe have done research, that are academics, that have been involved in the field of learning disability, particularly PMLD. Jim Mansell was a professor that worked at the Tizard Centre at the University of Kent and was heavily involved in lots of research and supporting people with PMLD and learning disabilities. He did a lot of work in the 80s around moving people out of long-stay institutions into the community, and was commissioned by the government in 2010 to write a report around services for people with PMLD. And the idea of this report was to highlight good practice and see how we might use that good practice throughout services so people would get a better deal. He wrote lots of recommendations from this report. Sadly, not many of them came to fruition, and we're still struggling to implement those recommendations in many places. However, his definition in this report is, as you can see on the slide. So he used the term profound intellect and multiple disabilities, so PIMD. You might see this in journals and articles written particularly by people in America and Australia. They may use that term. But Jim Mansell goes on to say that a person will have an IQ of under 20. I find this terminology quite difficult because, yes, we're talking about someone whose cognition is at an early stage of development, but IQs are quite hard to assess. So someone, when assessed by their IQ, if they're assessed by someone that's unfamiliar to them, may not present or may underachieve. If they're in a setting that's unfamiliar to them, it may be difficult. Also, people may have spiky profiles, so where they've got higher cognition in some areas, they may have a lower cognition in other areas. Therefore, I don't really like the term IQ under 20. I would prefer, as Ware, Hogg, Samuel and Pritchard say, we are talking about people at the early stages of development. They go on, so someone like Hogg goes on to say that someone between 18 months and 24 months. Ware talks about someone of the age of an under 2-year-old, and in practice, someone who is functioning at an under 1-year-old. The reason we talk about the early stages of development is, and compare it to young children, is we're trying to explain that people will have limited understanding. They be at the early stages of development, so they will like all the things that young children like. They will like the repetitive sounds. They will like the nursery rhyme type things. They may like some of the children's programs because it attracts their attention and it's of interest to them. Sorry, I've diverted a little bit, but we'll go back to Mansell's definition. He talks about a person having severely limited conditions. They may have multiple disabilities. They will have physical disabilities, autism, epilepsy, sensory impairment, hearing impairment. He then goes on to say people may not be able to walk unaided. They may have complex health needs and require interventions. So they may need suctioning, they may need nebulizers, they may need to be fed via a gastro feed, a peg feed. They may need suctioning. They may need a nurse with them 24 hours a day. There's lots of things they may need because of their complex health needs. He also goes on to say people will have difficulty in communicating, and they typically have limited understanding of expressing themselves and also understanding other people. They may use a few words and some symbols, but they're likely to have non-verbal means of communication. Often they'll have limited evidence of intention, and some people may have problems such as behaviour that challenges us, and also things like self-injury, self-harm. So that's his definition. As I've already said, Ware, Hogg and Samuel and Pritchard talk about people being at the early stages of development. You would have received a document with all the definitions on. When you're writing up AC 1.1, it's good to talk about generic terms around the labelling. So you might want to copy and paste one or two of those definitions in, explain your understanding of those definitions. So if ever we copy and paste anything in, we need to explain why we've used that quote or what our understanding of that quote is. So we then go on to look at other people and how they might term someone with PMLD. So Joanna Grace uses this really nice phrase, I feel, and she says that they're sensory beings. So they're sort of individuals experience the world primarily in a sensory way. So their experiences are dominated by the senses. She goes further to say, I'm trying to move the next slide, that a person can have an experience in isolation, and they don't have to associate objects to meanings. So they can live in the present moment, and they have an exceptional ability to occupy the present moment. They respond to hormones and natural cycles of the body, like light and dark and night and day. And I think we can all do that, but we've lost that ability. We're not so in tune with our natural cycles of the body. There's lots of interference that gets in the way for us. There's lots of stress. There's lots of things to think about. And sometimes we lose that connection. And that's why people with PMLD are often quite in tune with other people and can pick up on people's emotions and how they're feeling, because they are living in the moment and they can sense those things. She talks about us, the general population, that use verbal language as linguistic beings instead of sensory beings. So she has a divide, if you like. The sensory beings will primarily live in a sensory world where they present information presented to them should be in a sensory way, whereas linguistic beings like to have structure and sequence. They like linear things. They like planning and remembering and having order. So beginning, middles, and ends of things. I think we have a lot to learn from people with PMLD. Being able to live in the present moment and enjoy the present moment is quite a skill, and we could learn a lot from that. Okay, what I'd like you to do now is again go to your presentation and click on this YouTube link. And I'd like it is an hour long, and I'm not suggesting you watch all of it, but it is very informative, so you might like to watch all of it. But for the purpose of this training, I would like you to go to 4.43 and watch from there up till 6.28. And while you're doing that, I want you to write some notes to think about the words that they're using to describe people with PMLD. They're looking at characteristics and traits, and they're looking at them in a positive light. And I want you to think about how you might describe people in a positive light. Okay, so we're going to stop the webinar, and I'm going to give you a chance then to watch this clip and make some notes. And then when you're ready, come back to me. Hey, you've come back. Well done. I hope you found that clip really interesting. I found the whole thing very fascinating. There are so many clips out there that you can watch and you can learn from. So I could give you links to more if you would like them. So now I want you to write down the word profound in big letters in the middle of a piece of paper. And then you're going to think of some of those characteristics, some of those words that were used in that clip to describe someone with profound multiple learning disabilities. But I want you to think of words beginning with the letters of profound. So we're thinking of words describing words, or words that are characteristics of someone with PMLD beginning with P, then some words beginning with R and O, and so on. So you can stop the webinar and jot down a few of those right now, and then come back to me when you're finished. Okay, right. Hopefully you have done that, and you're now got a piece of paper in front of you that looks a bit like a spider's web with lots of words on it. I'm going to share with you my thoughts and what I jotted down earlier, so that we can have a compare and see if you've got some of those. I'm not expecting you to have all of the words. I've had lots of time to do this. You might not have. You could also take this to work and get your colleagues at work to help you complete this, to see if they can come up with other things. So let's have a look. So as you can see here, I've got quite a few, and sometimes I cheat a little, but don't tell anyone. So things like knowing isn't really beginning with N. We all know that, but sometimes you just got to break the rules. Anyway, Let's look at some of the things I've written. I've written things like non-judgmental. I think people with PMLD make no judgments about us. They accept us for who we are and what we can do. Forgiving, sometimes we can make mistakes. We find it hard to interpret someone's communication, and we might have to use a process of elimination. And people with PMLD are very forgiving that we actually, are not experimenting on them, but we are trying to work things out slowly. That is a great trait. I think we could learn a lot on how we should be from people with PMLD. Respectful is another one. If we have all these traits, obviously it makes us a much better person, and we can learn from those that sometimes struggle with life because of the challenges they face, but they're resilient and they're powerful and they overcome these. They rebound back from these challenges. They're also very fun-loving, great to be with, resourceful. If I was in a position where I had to communicate all my needs through non-verbal communication, I would find that so difficult. But people with PMLD are able to tell us so much information without words. It's incredible. So there's some of the things I've come up with. I won't go through all of them because we could just spend the whole webinar talking about those. But I think they are quite interesting, and I'd love to know what you came up with, and if you got something different, that would be great if you could let me know, because I could add them to the list. When you're writing up AC 1.1, I want you to think about some of these positive traits that you've highlighted and maybe write about those as well. Particularly things like being unique. All people with PMLD are people themselves. They're unique. They've got their own personalities. They're just like anyone else. They're very unique, and I think you should include that. Remember that we've got to look past the disability to the person. Nearly there. Okay, now this is something you don't necessarily have to write about, but I like to include it because throughout the years I've worked in the Learning Disability Service, which is many, I can tell you, more than 30. This has been an area that concerns me. They have always gone on about age appropriateness. Now, if you're working with adults, it can be quite challenging. If you're working with someone that's at the development stage of an under 2-year-old, but say at the age of 25, at the chronological age of 25, we need to get a balance between age appropriateness and stage appropriateness. Yes, we need to be age respectful. We need to respect that a person has life experiences, can go to the pub, can listen to rap music with swearing in, and do all the things that adults do. But we also need to be mindful of the stage of development someone's at. So if they're working at the early stages of development, they may like all the things that an under 2-year-old likes. If, for example, Thomas the Tank Engine is the connection, the way into engagement, should we exclude Thomas the Tank Engine because we've deemed it not age appropriate? If we do that, we're kind of limiting people's options. We're not listening to their voice, we're not giving them choices. But we've decided that that's age appropriate, therefore they shouldn't have it. And I think that's a dangerous road to go down. I think it's really important to make sure that we include stage appropriateness. I was at a conference a few years back where Penny Lacey was talking to an audience, and she coined the phrase really, stage appropriateness. And she said, if anyone challenges you about age appropriateness, talk about stage appropriateness. Tell them of the stage of development the person's at and why they like those things and why you're using those things. Don't worry about it as long as you're age respectful. Yeah, we're not going to call a 25-year-old man a little boy and speak to him in a patronising tone. That's not age appropriate. But we may use some things that young children use as resources because it's stage appropriate. I've sent you an article around age appropriateness. It was written for a journal, and the outcome of that is that really, if we don't think about the stage of development someone's at and only think about their age, then we are actually excluding people and limiting their options. So I think, although you don't need to write about this, it's really important to talk about it. Dave Hewitt is another one that talks about age appropriateness and says there's not really any academic research that backs up the need for age appropriateness. So look at his work as well around that. It's quite interesting. Okay, so I'm going to give you some facts now. There's roughly about 16,000 people with PMLD in the UK, and this is on the increase. As our medical knowledge gets better, we're able to keep premature babies alive from a much earlier age. And obviously this has an impact so obviously this may lead to disabilities, and then obviously those may be more profound. As many as 75% of them will have some sort of visual impairment, and over 45% of people with hearing loss will have some additional visual difficulty as well. So we are talking about engagement. We're going to be looking at some of the other channels to engage people. If you think about learning, we take a lot of information in visually, so about 80% of that is visually, and then when we look at hearing, we learn 15% of that is through hearing. So if we are working with people that have reduced sight and reduced hearing, we're left with the other senses or channels of learning, and they're the ones that we've got to focus on: the smell, the touch, and the taste. It could be vision as well, because it might be a hearing impairment that someone has, or hearing if someone has a vision impairment. So sensory diet is really important for people that have these challenges. So I'm just going to go through a few sight impairments and eye conditions with you so that you can see what challenges people have and how we might be able to support them when we're working with them. So we're firstly looking at a retinitis pigmentosa. This is a hereditary disease that affects the retina. So I'm going to show you on the next slide a picture of the retina. And what happens here, I'm going to let you have a look. It affects, see these black marks here? These are the pigmentation on the retina. And this causes difficulty and means that your sight is reduced so that you only have central vision. If you like, sometimes it's called tunnel vision. When you think about people with sight impairment, you often think about blowing everything up and making it much bigger. This isn't the case for someone with tunnel vision. If you blow it up and make it much bigger and present it in front of them, they're going to have to scan right across, moving their head backwards and forwards to be able to work out what the whole image is, because they've only got a small amount of sight. However, if you present it from further away, they've got more of a chance of seeing the whole object, and then you bring it forward for them to explore it in a different way, so touch, taste, smell, all of those sorts of things. It gives them more of a chance to work it out. You've also got to remember, for someone with tunnel vision, they have no peripheral vision. So if you're coming to them from the side, it makes it much more challenging for them to know that you're there. The other thing with tunnel vision is that it affects your depth of perception. So if you think about somebody in a wheelchair and in a corridor and people are walking towards them and you're pushing them, they can't work out how close a person is to them. So it looks like they might be coming straight towards them and they're in a very personal space, and really they're actually further away. And vice versa, someone might be further away and it looks like they're much closer. So you need to consider all of those sorts of things when you're supporting someone with tunnel vision. Think about visual clutter as well, how much information there is on the walls and in the classrooms or in the residential home or in the day service. Do we need all that information? Who's that information for? Can you make it less clutter? Can you make it more clear? It will help people, because what happens is they've got to try and interpret what they see, and if there's lots and lots of information, it's much harder for them to sort that out. Another condition that may cause tunnel vision is glaucoma. Now, we often associate that with people over the age of 40, but I do think it's important for you to consider this eye condition, because it does have an impact on your vision, as in you have tunnel vision. We're then looking at macular degeneration. Now, macular degeneration, so the macula is a tiny thing at the back of the eye here, and it's the size of a grain of rice, and it's responsible for our central vision and most of our colour and our fine detail. And when that degenerates, it means that we can no longer pick up that fine detail. We lose our central vision, and we might not see colour so well. And what happens is we have the vision in the middle is lost, and we're relying on our peripheral vision around the sides to be able to see. So a friend of mine was diagnosed at the age of 13 with juvenile macular degeneration, because often we associate age-related macular degeneration, but you can get other conditions. So overnight, at the age of 13, she went to bed and she woke up and she couldn't see very well, and she got a diagnosis of juvenile macular degeneration. Now, the thing with this is that when you communicate with her, she will look away. She'll turn her head to the side and she'll be looking out the side of her eye. And that's because she's trying to use the vision she's got. Now, it looks like she's not engaged or interested when you're communicating with her, when actually that's, far from the truth. So if you think of that for someone with PMLD, they may turn their head, they may look like they're not interested and get engaged, but actually they're making the most of the sight they do have and trying to look at you. The other thing with the loss of central vision is if someone's walking towards you, you may see an outline of their figure, but you can't necessarily see the fine detail of their face and things like that. So you miss out quite a lot of information. Then we have things like diabetic retinopathy, and this is like patchy vision, and it can cause challenges. When I do this workshop and I give simulation specs out and I get people to try them on, often they say this one isn't as bad as the others. Obviously, we're simulating the experience of being able to see in that way, and we can take those glasses off. If you had that vision all the time, you've got to imagine what it would be like, how hard it is to concentrate, how hard it is to interpret what you're seeing all the time. So people do need some downtime. They need to be able to rest their eyes. They need to be able to not have to focus on visual images all the time. So sometimes having some relaxation and some music and encouraging people to shut their eyes will help with that. Other conditions that I haven't got on the slides are cataracts. Cataracts can make things very, very blurry. And what I want you to consider is if someone has cataracts and they're in a wheelchair in a fixed position with their head facing up, how blurry strip lighting can be. And you need to consider where you place someone in a classroom, in a day service, in their room. If you're putting them directly under the lights, it can be quite painful. It can be disorientating, and you just see these blurry lights. It can be uncomfortable. We tried this on one of the training days, and people found it really disorientating and quite nauseous, made them feel dizzy. So you do need to consider where you might put someone, because they can't tell you that they're finding it difficult and they can't move themselves away. They're relying on you to do that. So think about the environment is really important. Another condition is where someone may have a stroke, a brain tumour, head injury, meningitis. They can all lead to sight impairment. Often it will be, if you imagine your eyes and you draw a vertical line down the centre of them, it will be half your field of vision on one side. So it might be half your field of vision on the left side of both your eyes. It depends where the damage is in the brain to where it affects the eyes. I worked with a young boy who had meningitis, and he had half his field of vision on the right hand side had gone. He'd lost that. And then if you imagine drawing a horizontal line across the eyes through the middle, he'd lost the bottom half of his field of vision as well. So effectively, he only had a quarter of his field of vision in his left-hand side of both eyes. So if you presented him with something, if he was sitting at the table and you presented him with an object in front of him, unless he had his head turned and he was looking down, he wouldn't be able to see that object. So you need to consider when you're presenting resources, when you're communicating with someone, where to place yourself in the resource to get optimum vision for that person. When we look at a person that is totally blind, sometimes we assume that it's only light and dark that they can see. We assume that it's total darkness that they can see, but often they have light and dark perception. So again, think about environments. If we're in a very dark area, if we put in a bright light, a person may be able to see that light. If a person is inside and they're looking out of the window and the sun is bright, they may be able to see the bright light. One of the training sessions I did, I wore a bright orange cardigan, and in a light environment, people were able to pick out very slightly that there was a different colour somewhere on me. They didn't know it was me, but they could pick out the colour slightly, not necessarily really orange, but very faintly. So you do need to consider the environment and contrasting colours and all of those sorts of things. And also things like shiny surfaces, because what can happen is the light can come in and shine on the surface and make it rebound into someone's face, and it can be very difficult for people to work out what is on that surface, what they need to be looking at. So think about the light. I've already talked about the visual clutter and that sort of thing. The other thing to think about is moving from one environment to another. So moving from a very dark environment to a very light environment, for anybody, can take them time to adjust their eyes. So think about when you've been in the cinema and you come out into the bright sunshine. It takes a while for your eyes to adjust. Well, if you've got a profound and multiple learning disabilities on top of that, or a vision impairment, and you come out of a sensory room, it's going to take you a while to interpret your new environment. You've come into quite a light environment. So a chap we used to work with would throw himself on the floor, and people assumed to begin with that that was his behaviour, telling everybody he didn't want to come out of the sensory room, he wanted to stay in there. But in fact, it was him throwing himself on the floor to ground himself. So he knew the floor was safe. It was a permanent object. It wasn't going to move. So he felt safe on the floor. So he would go to the ground and stay there to give himself a chance to orientate himself in his new environment, to work out where he was, to take in the new information, and then he was able to, once he felt safe and secure, stand up and move forward. Now, sometimes people will do this if they're in an unfamiliar environment and they are unsure. They may go to the ground and ground themselves because they know that that is a safe option. So consider, if you see someone doing that, consider what it is that's caused that, and maybe it might be to do with their sight impairment. The other thing that we haven't talked about is cortical visual impairment, so CVI. And this isn't an eye condition, it's more where the brain has been damaged and the brain can't interpret the message that is sent between the eye and the brain. So therefore, they don't know what they're seeing. So there's nothing wrong with the eye, it's more around the brain. Now, the challenge with this is that sometimes the eye condition can change. So all the things that we looked at earlier, the different types of sight someone may have, that could happen too. So although it's the damage in the brain, they may one day be able to see through the peripheral vision. Another day it might be tunnel vision. Sometimes it might be patchy vision. Sometimes it might be half the field vision. For us as people supporting, it can be quite hard for us to work out what vision they have and how to support it. So it's really important really to assess it most every day, to look at giving contrasting colours, see how they respond to that, presenting resources in different areas of their vision, see how they respond to that, using light and dark environments and see how they respond to that, because that will give you an indication of what they're seeing that day. It's very important to try. Okay, so that's part of the sight impairment. So you might talk about that in the AC 1.1 around a person may have a sight impairment. Then you might talk in AC 2.2 around how you might support someone with a sight impairment. We're now looking at sensory processing disorder, and people who have a sensory processing disorder find it hard to interpret the information that they're receiving through the brain, through all their senses. So it can be challenging to perform everyday tasks. So when we're talking about the senses, there are many senses, but I'm going to focus just on the 7 senses. So we've got touch, taste, hearing, sight, and sound. And then we're looking at proprioception, and vestibular. So your proprioceptive sense, now I want you to do this, is when you close your eyes, so close your eyes and put your finger on your nose while your eyes are closed. Did you do that? I've just done it. That is your proprioceptive sense. That's telling you where your finger is in relation to your nose and where your body is in relation to space. That's a subconscious sense that we don't often think about. And that's a sense that sometimes people with autism need to develop or have too much of. Then we've got the vestibular sense, which is the sense of balance. So if you imagine yourself in a lift, hasn't got any windows, so you don't know when it's moving, and you stand in the lift, you automatically know it moves because you can feel it, and that's the sense of that's your vestibular sense telling you about the movement of the lift. So they're the 7 senses. So someone might have hyper sensitivity, so they might be oversensitive to things. So if you think about someone with autism, for example, who finds noise uncomfortable, they might have to wear ear defenders to help them cope with that. And that is because they are hypersensitive to sound. If we're hypo, it means we're undersensitive and then we're seeking extra feedback. So if you think about someone who rocks a lot, I'm doing that now, I'm rocking in their wheelchair, that might be them trying to get extra feedback for their proprioceptive sense to work out where they are in space. Things that might help with that are things like massage, vibration. So a young chap I've worked with, he likes a vibro tube. He likes to be cocooned in material and have heavy things put on him because that helps him get feedback for his proprioceptive sense. So as soon as you do things like that, it helps him to calm down and relax because he's getting that feedback elsewhere. He doesn't need to vigorously rock all the time because he's getting that feedback from other ways now. I've put a hyperlink here to a YouTube channel from Sensory Spectacle. Becky from Sensory Spectacle does lots of clips on YouTube about the different types of behaviour a person may present because of their sensory processing disorder. She talks about the resources you could use to help with that and the reason why someone might be doing particular behaviours. She's really interesting to listen to, and her clips are great. And if it helps you to understand why a person is doing something, sometimes it helps you to understand how you might be able to support them better. So sensory processing disorders are something you might talk about in the definition, but you also might talk about them in the everyday needs, because if someone has a sensory processing disorder, for instance, as we said about that person with autism that finds sound uncomfortable, their everyday need might be for you to recognise that and for you to get ear defenders and to support situations where they might find uncomfortable. So we're going to go on now to Maslow's hierarchy of needs. So we're talking about AC 2.2 and we're looking at needs of individuals with PMLD. And the needs of individuals with PMLD are no different than you or I need, our needs. We all need these basic needs to be met. So food, water, warmth and rest, we all need that. We all need to feel safe and secure before we can go on to have relationships and feel loved and included, to feel valued and a sense of accomplishment. And then the idea is if we have all that, we can reach self-fulfillment, so we can reach our full potential. And people with PMLD are no different. They need all of those things. They definitely need to be included and need to be valued. So when we're writing up AC 2.2, you might like to write a little bit about that. You don't have to include Maslow, but if we're looking at referencing, it might help because we're talking about everyday needs. These needs need to be met, and they're no different than anyone else's needs. But other things that you might like to include in that are things like some people have written, for example, a day in the life of, and given us like a little case study, I suppose, of what that person needs. You could do that, or you could talk about the needs. You can't just bullet point and say they need medication, they need this. You need to talk about it in more detail. So obviously medication is part of that. I think it's really important. People with PMLD need people to support them who are familiar with them, who understand their needs, who personalise things, who use their form of communication, who interact with them, who provide social interaction, who provide a sensory diet. All those things are important. Someone may need daily personal care. They may need some health care, which we're going to talk about in a little bit more detail. May need position changing. All of those sorts of things. They obviously will need to be helped with feeding, so they may need their food liquidized, pureed. They may need thickening agencies added. They may need special cutlery to help them feed themselves. All of those sorts of things are things for everyday need. They need access to transport. They need to be included in society. They need to be seen in the community, so people become more aware of people with PMLD and more accepting of them. You could write so much about the needs. You don't have to write masses though, so don't get bogged down with writing every single need that they have. Just pick out some of them. So to start with, I want you to think about someone you know and just jot down 4 of their everyday needs, because this will then help you when you're writing your answer. You can talk about those and then talk about them in a little bit more detail. Say what the needs are and how you support someone and what happens if those needs aren't met. So I'll give you a chance to do that and then we're going to move on. We're on the final one now, and that is describing the health needs or explaining the health needs. So I'm going to give you a little bit of background information before we move on. You might like to include that in your answer, and it's particularly if you're working at level 3. There is some reference in your reading material that you can use, but also give me some examples of people you've worked with and the health needs that they have. So just to give you a little bit of background around health needs, in the 30s, the life expectancy was estimated to be less than 20 years. Obviously, since the 30s, we've moved on. We've progressed in the way we deliver healthcare and our understanding of medical interventions and all that sort of thing. So we're able to keep people alive for much longer. So life expectancy has increased. However, the more disabled you are, the more likely you are to die much younger than your non-disabled peers. And as you can see from here, this gives you the ages that a person may die. Obviously, that is an average. There are many people that die much younger than that. In the population in general, as I said already, there is an increase year on year for people with profound multiple learning disabilities. But if we look at the general population of learning disabilities, by 2021, there's going to be more than 1 million people with learning disabilities in the UK. Health inequalities. I wanted to talk a little bit about health inequalities because this is partly to do with health needs. People with learning disabilities, so we're talking about the general population of learning disabilities, not just PMLD, have poorer health than their non-disabled peers. And this is largely because of inequalities. accessing timely, appropriate, effective healthcare. So it might be that they do access healthcare, but actually it's at the wrong time. It's too late. The healthcare that they're offered may not be appropriate and it may not be effective. Therefore, they may become much iller or not get the interventions they need. Mencat did a lot of campaigning around this. In 2007, they wrote a report called Death by Indifference, and they investigated the untimely deaths of 6 people with learning disabilities whilst in NHS care. And they highlighted that actually the NHS were failing these people. Staff weren't trained adequately. They weren't involving parents or the people that know the person very well. They weren't communicating very well. They weren't always valuing them in the way that they would value a non-disabled person. So maybe they weren't offering them the same sort of services. And this highlighted the inequalities really that people were facing. Sadly, it didn't have a great impact on the way health service delivered services for people with learning disabilities. So Mencat, 5 years later, wrote another report called Death by Indifference, 74 deaths and counting, a progress report. And again, this highlighted the death of 74 people with learning disabilities and talked about all the things that went wrong and what we need to do to make sure people aren't put in that position again. There are lots of other research papers and reports that have been written around health inequalities, and here are some of them. So it might be worth mentioning in your learning outcome when you're writing it up around health inequalities. You might feel in your area that it is very good. You have got great learning disability nurses that understand the needs of people with PMLD, and they are there when someone is in hospital to support the family and the person in hospital. You may have great PMLD doctors. You may feel that your services around your area are good. It'd be worth talking to your colleagues and people you know to see what they think about your local area and how they support people with PMLD. I've heard, as I do training all around the country, I've heard lots of different stories about the healthcare service and how sometimes it can be very poor, and we still aren't very good at communicating and including families and people that know the person best, and making sure that we are effectively working with them to ensure the best possible outcome. But I'd love to know what your views are on that. Okay, so what I'd like to do now, because obviously the last bit is of AC 2.1, is to look at some of the more prevalent conditions or illnesses, if you like, within the PMLD population. And these 5 here listed, although the last one, it says seizures, should really say epilepsy, are things that are more prevalent for people with PMLD than their non-disabled peers. So I'd like you to think about these, think about why they may be more prevalent, and also to think about what support you might give someone to ensure this is reduced or prevented. So I'd like you to stop the webinar now and jot these down, write your thoughts down, and then come back to me when you're finished. Great, I hope you had lots of information to write down. So I'm just going to go through a bit of this now and to see if what I've written is similar to what you've written. So malnutrition, often when we look at obesity and malnutrition in the learning disability, put my teeth in the learning disability population, obesity is more of a problem than malnutrition. And that is because people may not understand that what they're eating is causing problems. They may not want to change their eating habits. However, for people with PMLD, other people are in control of their nutrition and feeding them. Therefore, obesity is not so much of a problem. It's more likely to be malnutrition. So if you think about malnutrition, this is when a person isn't getting enough calorie intake, isn't getting enough of the nutrients they need. This is often due to human error. So it might be that someone takes a long time to feed, to eat something, and therefore maybe people aren't giving them quite as much as they should. And gradually over a period of time, their calorie intake is less than it should be. It might be that someone is refusing to eat, therefore their calorie intake is less. It might be someone has been quite unwell and doesn't want to eat. It also might mean that someone therefore then has to be put on a gastro feed. So they might have a peg into their stomach, or they might have a nasal gastric tube, so that you can administer food directly into their stomach without them having to eat. So if they have an unsafe swallow, it would prevent all the aspiration and everything else that goes along with that. However, you think that a dietitian would calculate their calorie intake and how much feed they need. However, again, there could be human error. People could stop feeds and not communicate that they've started them again. People may miss a feed, and again, you can see how the patterns work. So that it might be just a small amount every day that's missed, but again, you can see the calorie intake reduced, and malnutrition might be an issue. So that's one area. We look at respiratory disease. This is partly a lack of mobility, mucus gathering on the chest, inhaling small particles of food. We've already said about aspiration. Someone getting respiratory tract infections from aspiration or reflux, so they may have swallowing difficulties. Remember, we're saying how we might support someone. So we might say, I forgot to mention, for now malnutrition, we might say people need thickening agents in their fluids. They might need support with feeding. We might need meal mats to explain how someone, what someone consistency of food someone has and what equipment they need. We also might need to record. We definitely need to record how much someone's eaten and when they haven't eaten enough, so that we can have a pattern to show if their calorie intake has reduced. But coming back to respiratory disease, people may need suctioning. So to get the mucus off the chest, they may need someone to help them, so they suction the mucus out. Someone may need a nebulizer. They may need a chest physio daily to help them release their mucus. They may need a change of position. Again, this all helps with respiratory disease. They may need interventions where they have to go to hospital and have intravenous and antibiotics to prevent pneumonia and things like that. Moving on to osteoporosis, often this is due to medication. So medication can cause osteoporosis. Again, a lack of weight-bearing exercises. So it's really important to try and encourage things like hydro, where someone can move their limbs, maybe physios to do some exercises with them, people being put in standing frames and that type of thing to help with strengthening the bones. Gastrointestinal disorder. This can be due to medication, poor diet, incorrect posture when eating, lack of exercise, inadequate hydration. When we look at gastrointestinal disorders, it can mean constipation. Constipation can be a big issue and can be very uncomfortable and cause a lot of pain. So we need to monitor this and record it so that we know if someone is constipated. If they are, we can work around that and give people medication. But if we leave it, it can be quite catastrophic. I was reading an article the other day about a man with learning disabilities. He didn't have profound learning disabilities, but he had learning disabilities, who died from constipation because nobody had picked up on it and nobody had dealt with it. Imagine the agony that person must have been in before they died. So it's really important that we look at those sorts of things. Then we have a high level of bacteria that can be picked up in a shared accommodation or a day centres, that can be transferred from one person to another. Now, this can lead to ulcers, and if the ulcers aren't treated, they can perforate. It can also lead to stomach cancer as well. So it's really important that we have a good hygiene regime, so we ensure our hands are washed at all times, and that we're not spreading infections. So there's some of the things that we're going to talk about. The last one is epilepsy. So if you're going to write about epilepsy, I want you to explain a little bit about what epilepsy is, what a seizure might look like for that person, how you might support them. What is their seizure protocol? What happens when they come out of the seizure? Do they need medication? Maybe they need hospitalisation. Talk about what happens with the people you support. So here I've saying there's three main groups for the causes of epilepsy. The first is things like head injury, infection, stroke, a tumour. They're all things that may cause epilepsy. Another area that may cause epilepsy is genetic. You may inherit epilepsy from a parent. It also may be part of your condition that you have epilepsy. And finally, the last one is that they just don't know. They don't know yet what the cause of it is for some people. So I'm quickly just going to go through some of these health problems. We've gone through a lot of them already. You might want to write about some of these as well. You don't have to write about everything. And as I've said in the reading material, there is already some of that stuff. Diabetes is one thing that we can quickly look at. Diabetes, if we're talking about diabetes and a person may need insulin, they may need their sugar levels tested, they may need support with having frequent snacks and drinks, they may need to be monitored to see if they're becoming unwell, and this all needs to be recorded. If we're looking at muscular skeletal impairments, we may be talking about a person wearing a body brace to support their body. They may need to wear splints and things like that, all to help support their body. We may have to put them in different positions. They may need to be in standing frames for periods of time, and this all helps to support the structure of their body. Again, people have to have these sometimes moulded, especially the braces, to fit them, and they can be a little bit uncomfortable. So you have to watch them. You have to only put them in them for set periods of time. You have to check for marking or bruising, and any time there is any of that, you have to report that so that they can look at whether a person's grown out of it or they need a different type of brace. They may need a new brace, the brace might be broken. All of those sorts of things need to be considered when you're supporting that. Poor uptake of national screening and poor uptake of immunisations. Quickly just touch upon. This is more prevalent for people with PMLD, and maybe it's because parents find immunisations, people have a weaker immune system, and if we're then going to immunise them with a part of a disease, parents might think that their young person, their child, is more vulnerable and therefore choose not to have an immunisation. Also, with all the talk about immunisation causing autism and things like that, parents might be wary of these immunisations. However, without these immunisations, like MMR, we can, if a person becomes very unwell with one of those diseases, they can actually end up with brain damage. And things like meningitis, which can cause them to have a severe learning disability. Therefore, we do need to think about those. If you're looking at national screening, things like as you become older, there's screening that people attend. Sometimes this isn't picked up on for people with more profound disabilities because it's quite hard for them to access it. How do they access it? How do you explain it to them? What is the reason for it? And therefore, they may miss those screenings. So then those sorts of things aren't monitored as easily. Sleep disorders, this might be due to your condition. It might be that you need a special sleeping program where you need equipment to help you lay down and sleep. Some people think about the impact it has if you yourself don't get sleep. Think about how you feel and how it's hard to interact and concentrate. Think about that as the people you support. Finally, I think the last one I'm going to talk about is oral health. Poor oral health. Imagine if someone else was cleaning your teeth, how it might feel for you. If you've got dysphagia and an unsafe swallow, someone is still cleaning your teeth and you've still got saliva to deal with. You might decide, actually, I don't want this. I'm going to shut my mouth and they're not going to clean my teeth. This obviously has an impact and will cause tooth decay and might cause abscesses, tooth extractions, etc., etc. So oral health care is really important, but can be quite tricky for carers, support workers, parents to manage. So it's something that needs to be considered. So these are some of the health problems that you might like to write about. You don't have to write about every single one of them, but what you do need to do is think about, I'm just going to skip that slide a minute, the impact of illness. Because when I mark your work, I then send it to the IB and internal verifier, and she always goes on about the impact. What is the impact on this for the person and their family? So I want you to write something about the impact. Think about people who may not be able to communicate when they're in pain, how hard it is for them to concentrate. Think about when you're in pain yourself, what it's like. Sometimes you may just want to go away. And if you're unable to tell someone, therefore you can't take a painkiller, for example, if you've got a headache, that must make it even harder. Some people may present behaviour that challenges us because they're trying to communicate they're in pain. Sometimes by hitting yourself in the face, it takes away the pain from the abscess, and therefore, although it seems a bit bizarre to do that, people might present that sort of behaviour. If people are very unwell, they may have to go to hospital. They may miss large amounts of college, school, daycare, all of that sort of thing, and they may lose skills they've already learned. They may become what appears to be very ill very quickly and need medical intervention, when really it may be that we haven't picked up on those signs or that someone's in pain or discomfort. It's really important to have pain monitoring tools, something like Distat monitoring tool, so that you can record when and monitor when you feel someone's in pain. Even if you just have an inkling that there's something different, behaviour slightly different, someone is just responding in a different way and you're not sure that they're quite right. You can't put your finger on it. They haven't got a temperature, they're not red, their eyes aren't watering, they don't appear to be in pain, but there just is something not right. It is worth communicating that. I once worked somewhere where a young man didn't show any signs of pain. Someone felt there was something not quite right, but they couldn't put their finger on it. It wasn't until a week or so later that that person became seriously ill and then was rushed to hospital with sepsis. Now, I'm not saying that it's down to the people that were supporting them because they didn't pick up on his signs of pain, because it was very difficult. But if everybody started to get an inkling that actually he's not himself, maybe, and it was all communicated at that point, maybe they may have picked up at an earlier stage that he was unwell, and it wouldn't have been such a serious illness. I'm not saying it would or wouldn't, but I'm saying at least there would have been the opportunity to discuss it. So even if you feel a little bit that someone is not themselves, it's worth recording it. It's worth discussing it with your friends and colleagues, with your colleagues, or if you're at home, if you're a family member, with your family or people that know that person really well, so that you can pick up on those very, very subtle cues. It might be nothing, but it's worth considering because obviously you could have serious health implications. Okay, the last thing, and then I'm going to stop because I think you've had enough of my voice, is cross-infection. I touched on it a minute ago when I talked about uh, infections in residential settings and daycare. It's really important that our personal hygiene is we have a strict routine and we make sure that we don't cross-infect. Uh, it's really important that we're able to wash our hands, use barrier creams, make sure that we use gloves and all of those sorts of things, and we dispose of uh, things that need to be disposed of. So if someone has been unwell, so those germs are put away as quickly as possible so that we can't spread the infection. We need to control infections as much as possible and shut them down. As I said already, people with PMLD tend to have a weaker immune system, so we'll pick up those illnesses much quicker and become much iller. So it's really important we support those sorts of things. So you could write about that if you choose to. Move to the last bit because we're on the last slide. Yay! So what I want you to do now is to go away and write up those 3 learning outcomes. So remember when we're writing about AC 1.1, we're talking about a working definition. We're not talking about a clinical diagnosis. We're talking about characteristics that people with PMLD may have. Remember, it's going to be that they will have significant learning disability. They will have multiple disabilities such as a sensory impairment, hearing or visual impairment, physical impairment. They may have autism, they may have complex health needs. So you're writing all that, but then you're going to talk about them being unique individuals with their own personality traits, with their own ability to communicate in a personalised way. It may be non-verbal, and they may use vocalizations, but they have an amazing ability to communicate their needs, even though we sometimes don't have the ability to interpret those communications. So maybe something around that. AC 2.1, we're talking about the healthcare needs. So you're picking out some of the more prevalent illnesses that someone might present. You might talk to begin with about accessing the inequality to accessing healthcare and how people may need hospital passports. They need people that know them very well to go with them and be their advocates. And then you're going to look at some of the health problems that people might have, particularly things like dysphagia, respiratory disease, gastrointestinal, things like that you're going to talk about. What I want you to talk about is what they are, why they might have them, how you might support someone to prevent them getting worse or prevent them from having that in the first place, and then think about the impact that has. Remember, there is referencing that you can put in through the reading material. And finally, at AC 2.2, we're talking about needs. So you might start off with Maslow's hierarchical needs and talk about how important it is to have your basic needs met before you move on to love and affection and being valued and self-fulfillment. And then talk about some of the daily needs that people that you know will need to be supported with. So it may be personal care, communication, access in the community. Uh, it might be medication, help with eating and drinking. So they may need thickening agents in their fluids. They may need help with feeding. So they may need specialised equipment, special spoons, special plates, and that sort of thing. These are all things you need to write about. So I'm going to stop talking and end the webinar because I think you've probably heard enough from me for now. But please, if you have any questions, anything you want to discuss, please do not hesitate to contact me. I'm really happy to hear from you. Emailing is best, but I'm happy for you to phone me as well. Sometimes you might just get a voicemail, but please do leave a voicemail, or you could send me a text, and I will respond as soon as possible. So happy writing. I look forward to receiving your first piece of work, and I can't wait to present with you the next webinar. So bye for now, take care and speak to you soon.